Picture waking up tomorrow with your blood pressure exactly where it should be. No dizzy spell when you stand up, no racing heart after your first cup of coffee, no 2 a.m. trip down a dark hallway. Just steady, controlled pressure. Because your medication is finally doing the job it was actually prescribed to do. That's not a fantasy. That's what happens when blood pressure medication is taken the way it was designed to be taken. And the gap between that and what most people actually experience isn't a different prescription, more exercise, or a stricter diet. It's 5 specific pieces of information almost nobody hands you at the moment it matters. I'm Dr. Claire Brooks, and here's what I've seen over years in practice. The overwhelming majority of people taking these medications daily are making at least one of 5 specific mistakes. Not because they're careless, but because nobody ever explained it to them. Not at the pharmacy counter, not on the label, often not even during the appointment where the prescription was written. Today, that changes. 5 mistakes, 5 clear fixes. Stay through all 5 because the last one may matter more than the other 4 combined. It's about a single factor your doctor has almost certainly never brought up, and it could reshape your entire medication schedule. Here's something happening in millions of kitchens every single morning. You wake up, take your blood pressure pill, and a few minutes later, you're pouring coffee. Feels completely responsible. If you're on a beta blocker, and a large share of people managing hypertension are, that routine is quietly working against you. Beta blockers lower blood pressure by slowing your heart rate and softening the force of each contraction. That's the whole mechanism. Caffeine does the exact opposite. It stimulates your nervous system, raises your heart rate, and triggers a temporary blood pressure spike. Put both in your bloodstream within 20 to 30 minutes of each other, and your heart is getting contradictory signals at the same time. Some people feel palpitations, that fluttering or pounding in the chest. Others feel tightness. Most just assume that's how mornings feel, when really it's the coffee and the pill having an argument nobody invited them into. The fix costs nothing. Wait at least 45 minutes after your beta blocker before any caffeine, coffee, strong tea, energy drinks, pre-workout, all of it. Give the medication time to establish itself first. Take your pill, get dressed, do your morning routine, then have your coffee. How many years have you been stacking your morning pill and your morning coffee without anyone mentioning this? Tell me in the comments. I read everyone. This one surprises almost everyone the first time they hear it because it has no obvious relationship to medication at all. Grapefruit. I want to be precise. This isn't a blanket citrus warning. Orange juice, lemon, lime, no issue. The concern is grapefruit specifically, and to a lesser degree, Seville oranges, which sometimes show up in marmalade. Grapefruit contains compounds called furanocoumarins that block an enzyme in your intestinal wall, CYP3A4I, which is responsible for metabolizing calcium channel blockers like amlodipine, felodipine, and nifedipine. Block that enzyme, and the medication doesn't clear at its normal rate. It accumulates. Blood levels can climb to 2, 3, even 4 times the prescribed concentration without you taking a single extra pill. What follows isn't a gentle dip in blood pressure. It's a crash, severe dizziness, possible fainting, disorientation, and in some cases, the exact cardiovascular event the medication was supposed to prevent. Here's the detail that makes this genuinely hard to manage around rather than avoid outright. The enzyme block doesn't clear in a couple of hours. It can persist 24 to 72 hours. A glass of grapefruit juice tonight can still be interfering with tomorrow morning's pill. Spacing it out doesn't help. Timing doesn't help. If you take a calcium channel blocker, grapefruit comes off the menu completely. Not reduced, eliminated. Check your medication leaflet or ask your pharmacist directly. It takes 30 seconds to find out if this applies to you. Mistake number 3, the water pill timed to wreck your sleep. This one disproportionately affects older adults, and the consequences don't show up right away. They show up at 2 a.m. in a dark hallway. Diuretics, water pills, are among the most commonly prescribed blood pressure medications. They help your kidneys clear excess sodium and fluid, which reduces the volume your heart has to push against. The mechanism is sound. The timing is where things go wrong. Take a diuretic in the afternoon or evening, and your kidneys respond overnight. The medication is doing exactly what it's supposed to, just at 2 a.m. instead of 2 p.m. You wake up, then again an hour later, then again before dawn. For someone in their 60s or 70s, this isn't just an inconvenience, it's a specific, predictable chain of events. Blood pressure is at its lowest point during sleep. Reflexes are slower. Balance hasn't fully engaged. The urge wakes you, you sit up fast, swing your legs over, stand, and your blood pressure drops sharply with the sudden change in position. That's orthostatic hypotension. And in someone whose pressure is already reduced by medication, sleep deprived, and moving through darkness, the compensatory response can be too slow. The result? Dizziness, loss of balance, and too often, a fall. Hip fractures in older adults are not minor events. Surgery, extended hospitalization, 6 months or more of recovery, and for some people, a permanent loss of independence. In a meaningful number of the cases I've seen, the original trigger was a water pill taken at the wrong time of day. The fix requires no change to the medication itself, just the clock. Take diuretics in the morning, ideally before noon. Bathroom trips happen in daylight while you're awake and steady, and you sleep through the night. If you're currently taking one in the evening, don't switch it yourself, but bring it up directly at your next appointment. Is there a clinical reason I shouldn't take this in the morning instead? In most cases, there isn't. Mistake number 4, I'll just take 2 to catch up. This mistake comes from an understandable place, the instinct to fix a slip. It's early afternoon, you realize you forgot your morning pill, and the thought lands immediately. Take 2 now, cover both periods, problem solved, please don't. Blood pressure medications are calibrated for a specific absorption curve. A double dose doesn't spread protection across 2 windows. It compresses it into one, and your blood pressure can fall sharply and suddenly in a way your cardiovascular system isn't prepared for. Extreme dizziness, nausea, cold sweat, fainting, and if it happens while you're standing, walking, or driving, you've traded one risk for a worse one. Here's what to actually do. Check your medication's specific missed dose instructions. Most follow the same general pattern. If you remember within a few hours, take it then. If you're close to your next scheduled dose, skip the missed one and continue as normal. One missed dose, handled properly, is almost never a real problem. If you're unsure, call your pharmacist, not the doctor's office, the pharmacist. 2 minutes, and they'll have your specific medications guidance on hand. And if you find yourself forgetting doses regularly, that's worth a direct conversation at your next appointment. Some formulations only need dosing every couple of days, which may solve the problem entirely. Mistake number 5, the one that happens, even when you do everything right. This last one is different from the first 4. Those were about errors, interactions, timing slips, missed doses. This one can happen even when you take your medication exactly as directed, same pill, same dose, every single morning without fail, and it may still not be giving you the protection you think it is. Ask yourself, when does your body actually need blood pressure support the most? Most people assume during the day, under stress, while active. Reasonable guess? Not quite right. Blood pressure isn't constant. It follows your body's internal clock. During sleep, it drops, reaching its lowest point in the early hours. Then, typically between 5 and 9 a.m., before you're even out of bed, before coffee, before any activity, it begins rising sharply. Cardiologists call this the morning blood pressure surge, and in people with hypertension, it can be dramatic. 30, 40, sometimes 50 points within an hour or two, while lying completely still. This isn't random. Cortisol rises before dawn, your nervous system shifts from rest toward readiness, and blood pressure climbs as part of that preparation. The problem is that same surge places real strain on your cardiovascular system, and heart attacks and strokes cluster heavily in that 6 a.m. to noon window, not from a stressful breakfast, but because pressure was already surging before the morning pill had even started working. This raised a genuinely interesting question in cardiology. What if the medication were taken the night before instead, so it's already active when the surge hits? This is exactly what the HIDJA chronotherapy trial set out to test. One of the largest hypertension studies ever run, following close to 20,000 patients for years, comparing morning dosing against bedtime dosing. The bedtime group showed better control during that early morning window, and the trial reported a striking reduction in cardiovascular events for that group. I want to be straight with you about where this stands today because it matters. The Hygia results made headlines, but they've also drawn real scrutiny from the broader cardiology community over how the trial was run. And a larger, more recent trial, the Time trial, tested the same morning versus bedtime question and did not find a meaningful difference in cardiovascular outcomes between the two groups. So, this is not settled science with a guaranteed 45% risk reduction sitting on the table. What it is a legitimate open question, and the timing of your medication relative to your own blood pressure pattern is a real clinical variable worth discussing, not a gimmick and not a guarantee. What this means practically, don't switch your own dosing to bedtime based on this alone. What it does mean is that this is worth raising directly with your doctor. Ask specifically whether your current timing fits your individual pattern and whether the evidence on chronotherapy has anything meaningful to offer your specific case. If your doctor is current on this research, they'll have a real answer. If they're not familiar with it, you asking is exactly the kind of question that opens a more useful conversation. Before you go, two more things. Some of what I've covered assumes a typical pattern, and not everyone fits it. In roughly 30 to 40% of people with hypertension, blood pressure doesn't dip properly overnight. Some show almost no drop at all, and others, called risers, actually run higher overnight than during the day. For these patients, shifting medication toward bedtime carries a different risk profile entirely and needs individual evaluation, not a blanket recommendation. If your hypertension has been genuinely hard to control, ask your doctor whether you've ever been assessed for this pattern. Second, if you're doing everything right, correct timing, no interactions, no missed doses, and your blood pressure is still poorly controlled, ask about sleep apnea. It's significantly underdiagnosed, especially in men over 50, and it's one of the most common drivers of hypertension that doesn't respond well to medication. The repeated drops in oxygen during sleep apnea trigger repeated stress hormone surges and blood pressure spikes through the night. And no amount of medication adjustment fully compensates if the underlying cause goes unaddressed. Heavy snoring, waking unrested despite a full night in bed, or being told you stop breathing while asleep, all worth raising at your next appointment. What to do with this? Write down which of these 5 apply to your current routine. Write down one question about chronotherapy to ask your doctor. If sleep apnea has never come up, write that down too. One appointment, a short list of specific questions, that's the whole action item. Which of these 5 was new to you? The coffee timing, the grapefruit interaction, the diuretic at night risk, or the morning surge research? Tell me in the comments. It genuinely shapes what I cover next, and I read everyone. This video is for general educational purposes only and is not personal medical advice. Never change your dosing schedule, stop a medication, or adjust timing on your own. Always work through changes like these with your prescribing doctor or pharmacist.